I am Nancy Buyle. I am on the Kevin Song Advisory, and I am here to introduce Cheryl King, who will be our next speaker. And Dr. King, she directs the Depression and Suicide Prevention Program at the University of Michigan. She's dedicated to developing and improving, or the center actually, the program is dedicated to developing and improving suicide risk and screening risk assessment tools and interventions for our folks in suicide. She is leading currently 3 research projects, and one that is very interesting that she's not talking about this time, but maybe next year, is 24-hour warning signs that we may be seeing in our youth who are considering attempting suicide. So today, though, she's going to talk with us for a few, about 20 minutes, I think, on connection and the work that she's been doing on connection, which is the theme, hopefully you're picking up on from the movie. Thank you, Cheryl.
I'm okay with will that work?
Yeah.
Right now, it's not showing on the screen.
Yeah, I got it.
Okay.
Okay, sorry. I'll go put it up.
No, you're good.
There you go.
Good morning. That film was fabulous. I hadn't seen it before, but it is it was inspiring. And every single one of those programs emphasized connections with other people. And I think for all of us here who care so much about the youth in our communities and are working in our own ways toward suicide prevention, it's been really difficult to see the rates continue to rise despite our efforts. And I think about it, I have been a clinical psychologist and a scientist for over 3 decades. At the University of Michigan, I've worked in this area my entire career. And, you know, it's really humbling to work on something so hard for so long and not feeling like we're making a bigger dent than we are in the problem. And I think about it, you know, we've learned just an enormous amount. We understand suicide so much better than we did even 1 or 2 decades ago. But how do we translate this new understanding to preventing more suicides? And as I think everyone here knows, there is no single solution. There will never be a single solution or a single program that does it. Yet today, I'm here with just one single overriding message, and this is about the importance of connections and connectedness. And I can say, as a mental health professional, as a parent and grandparent, as a member of my community, and just looking at the research, that over the years, more and more of it is converging at this point that we can do a lot of other things, but at the end of the day, we really need to have connections with other people, and that's going to be the single message. Suicide risk, how much have we all learned? And it is a lot. We know much more about these risk factors for young people. Some of them relate to their social world, some of them don't. Some of them relate to mental illness or psychopathology or alcohol or drug use, trauma. There are so many risk factors. Yet when we work with young people, our sole focus can't be treating and taking away problems. We have to also be building them up and building their connections, their value, our care for them. And what is connectedness? I think it was put so well by so many people in that last film. It's, I am not alone. You know, I feel connected to someone. I trust someone. There's someone out there that I can share who I really am with that person. I can share my struggles. They won't walk away. They won't laugh at me. They'll hear me. Or I just feel good. I feel connected with these people. So how do we get to a place where more of our young people feel that they have these kinds of connections where they matter, they're trusted and they trust, and they feel comfortable with another person? So as a scientist, it's a very strong identity. As you know, I've been doing it a long time. So of course I'm going to share some findings. And because some of these are very new, and they're from really large studies we've been doing nationally. They have been supported by the National Institute of Mental Health, by the Centers for Disease Control. And this is one that we call emergency department screening for teens at risk for suicide. And I've been working with 15 pediatric emergency departments nationwide to try to develop a more optimal screen, a way to recognize teens who come into general medical emergency departments. Why are we working there? Well, because we want to find the girls and the boys at risk. We know boys die by suicide more often than girls. And general medical emergency departments is one place where girls and boys come in pretty evenly. And some of them are at elevated risk because of alcohol poisoning, fist fights, car accidents, traumas. But what we've been doing is we have developed a screen. It's working really well. I'm not talking about it today, but because we had several thousand young people in this study, we were also able to look and see what predicted which of these young people made a suicide attempt within 3 months of being in that emergency department. And we looked both, what are the single predictors of who made a suicide attempt? And then we look to see, what if you put them all together? What can you pull out? What seems to matter the most? And look at the single predictors. Basically, because this study is so large and federally supported, we replicated every known risk factor for youth suicide. These are all the risk factors you've learned about. Past week SI, suicidal ideation. NSSI, non-suicidal self-injury, self-harm, like cutting. Have they made a suicide attempt in their lifetime? How long is it that they can't get thoughts of suicide off their mind? They're going over and over, maybe for hours a day. Depression, alcohol use, drug use, anxiety, homicidal thoughts, and even more. Every single one on this list, significantly, that's scientific for, it didn't happen by chance, less than 5 out of 100 times, predicted who made an attempt, being highly agitated, expressing hopelessness, having histories of abuse, poor sleep, poor quality of sleep, being victimized, being a bully toward others. And certainly sexual minority identity, gender minority identity, girls more likely to make attempts than boys. But then what happened when we developed a model where we put them all together to see what holds? Because what you will find is many of these are overlapping. And once you put one in the prediction model, the others just are canceled out because these things tend to go together or co-vary. And this is what we land with when we put them all in one model. We're down to only 4 things. Current suicidal thoughts, the lifetime severity of suicidal thoughts, and I'll come back to that, a lifetime history of suicidal behavior, and connectedness. They are the only 4 things of that list of more than 30 that stay in a model when you put the model together. It can be school connectedness or social connectedness. And these were so powerful, and I have to tell you, we measured each of them with only 2 questions. You know, school connectedness is the sense that I belong there, I'm comfortable there, there's someone I can go to there. And social connectedness is the same idea with a friend. I think the reason we need both recent suicidal thoughts and lifetime is because we do have young people who choose not to share their current suicidal thoughts. You may have worked with people who struggle with addictions. It's not uncommon when we meet them, including young people, teenagers, that they tell us that's not a problem anymore. They stopped that last week or 2 weeks ago. It's a much easier way to talk about ourselves than to say it's a current problem. Some youth don't share that I'm having suicidal thoughts this week, but they do share that they used to and how severe they were. And it's important to get both of those. And then the connectedness. Now I want to turn and tell you about some work that I have done with my team for 15 years. And just this last year, we were able to do a long-term follow-up and look at mortality outcomes for the young people that we worked with from 2002 to about 2004 or 5. And this was an intervention we developed called the Youth Nominated Support Team. We developed this for teens who were acutely suicidal and hospitalized to stabilize and keep them safe before they were discharged back to their families. And I had been working when I was recruited to Michigan. My first job was as the lead psychologist for the adolescent psychiatric inpatient unit. This was actually in the late 80s. And the primary reason that young people are psychiatrically hospitalized is suicide risk. And I worked with a lot of suicidal teens. We worked very hard to evaluate them. We developed strong treatment plans. We didn't always link them to services right away because they might have to wait 1, 2, 3 weeks for a first appointment. But we almost always discharged them with the recommendations for psychotherapy of some kind and medication of some kind, so what we think of as combination treatment. But what was my experience with these families, and this was really the roots of developing this intervention, they were pretty much universally overwhelmed with the fact that we were going to discharge their teen so soon, and they were going to wait 1, 2, 3 or more weeks for a first appointment. After they had left their young person, it's very difficult for a family, right? It's traumatic to realize your teen is in that state and needs hospitalization as at high risk for suicide. On the unit, we were watching over them pretty much 24/7. And then maybe 10 days later, 15 days later, you're ready to go. You're not having suicidal thoughts today. And no one, it's you and your parent or parents are on your own. Some of these parents were absolutely healthy, well connected with their youth. Some of them had certainly their own struggles. And for those, I thought we were putting them past their emotional tipping point or behavioral, asking them to watch over these teens, to try to talk with their teen, sometimes, as we know with teenagers, they don't share a lot with their parents. But no matter how well the parents were doing or their relationship with their youth, they were pretty much universally overwhelmed. And yet our treatment recommendations were in line with what insurance would reimburse. So I guess I'm getting tired of what insurance will reimburse. And what we developed here is, how can we help these youth and their parents? How can we reach out and build a stronger network around the teens? And it's the youth-nominated support team. And what happens with this is that the youth nominates up to 4 adults they trust. They don't have to be close and doing a lot with them now, but they think these adults could be helpful to them when they leave the hospital. They can nominate a parent as one of these. And what we found is, on average, they all ended up with more than 3 adults in the program. So I did this with 450 acutely suicidal teens from Havenwood Hospital, Metropolitan Detroit, and from the University of Michigan Child and Adolescent Psychiatric Hospital. It was a randomized clinical trial, like a flip of a coin. Half of them received usual care, half of them received usual care plus the YST intervention. We found that almost the majority of all these adults were willing to take part with the teen. I think there were 2 keys to its success. One was that the youth nominated them. They felt a connection to these adults. We had involved aunts, uncles, grandparents, teachers, coaches, youth group leaders, a rabbi, a friend of the family who lived next door. I think the second key is that these adults were not left on their own. I think everyone in this room would want to help a suicidal teen if they lived next door. But what happens? We're not sure what to say. We're afraid we might make it worse. We know there's a lot going on at that house and maybe we shouldn't intrude. We actually don't know how to put in words and how to be helpful. So I think the other key was we brought these parents, these adults in. The intervention was with the adults, not the youth who were already getting combination treatment. We helped them understand what was going on with the youth, and we had weekly contact with them for 3 months to help them answer their questions and support them in this role. And what did we find? Well, in the short run, the youth with YST had more rapid reductions in suicidal thoughts, and they did get more treatment in that first year. So the role of the caring adults is to care and support, to encourage treatment adherence, and when there's an opportunity to lean on the side of positive behavioral choices. But what we found 12 years later, on average, was fewer deaths in the group with YST. Now, obviously, we need to replicate this, but why might this be? So many of these adults were already in their lives. They knew them, we didn't assign them. But now they had brought them in much closer, a closer connection. They shared their treatment plans. These people understood why these treatments were recommended. They understood what the youth was struggling with in the most personal way. They had been invited to contact the youth proactively. They had the words to say when they did that. So I think even though we only were supporting the adults for 3 months, they continued in their lives as they had been, but in a different role with the young person. And this shows, for those of you who are inclined toward graphs, across the horizontal, or the x-axis, we have the number of years since we worked with them in the hospital. And each of those ticks down is a death in the lines. And the YST group is on the top, and the group that received treatment as usual is under that. So just a couple more examples of connections. Some of you may know the Sources of Strength program. It's been evaluated also in a scientifically strong clinical trial. where you have trained peer leaders really focusing on the idea of communicating with adults, finding adults you trust, you connect with, going to them when you need help or a peer needs help. And again, the findings are very positive. It increased students' beliefs that adults could help and that it's acceptable to approach these adults. And this was even more true for students who had low levels of engagement initially, students who were struggling more initially and had fewer connections. Another one that I want to share just because I'm so taken by it personally is the notion of invisible mentoring. And I think what happens here or can happen in a school is that all the staff come together and you have all the names, for instance, of the students in the school up on a board or on sheets. And the staff members mark or circle all the students they know or feel that they know, they might have a conversation with, they feel some connection with. And lo and behold, when they're done doing that, you notice that there are some students up there, names, that not a single adult in the school indicated they knew or had any connection with. And then the school can systematically go about having adults reach out to those youth to build some connections. And I think especially this one, when I look at our recent data, that's actually quite powerful on this multivariate model of prediction of suicide attempts with not just the psychiatric symptoms or mental health issues we usually think about being predictors, but that second domain of school or social connectedness. Because without it, one, we have higher risk, but two, I think it often takes the connection to get to help. So it's like a double whammy without connections. You're at higher risk, and you've got no one to share your struggle with, or no one who has eyes on you looking out for you to help you get help. So let me stop there, and I would love to talk with any of you like individually, but I do think that building connections is maybe this next step that could really make a difference and begin to drive down the suicide rate. Thank you very much.